Good afternoon, everyone. I hope that's better. Welcome to today's seminar, Policy Options for Urban Health and Education, Insights from Karnataka, 2014 to 2024. Thank you all for taking the time to join us today. We also have some outstation guests online with us on Zoom. Thank you, and please feel free to engage with us through the Zoom chat. Before we begin, I'd like to briefly introduce our presenter and panelists for today. The research presentation for today's event will be delivered by Dr. Priyadarshini S. Priyadarshini is a fellow with the Human Development Research Program at CSEP. Her work focuses on the political economy of policy making with a focus on education, history of public institutions, and grassroots political ideas and politics. We're pleased to have two distinguished discussants with us today. Mr. Sanjay Kaul is a former IS officer, corporate leader, development policy analyst, and author. During his long tenure as a civil servant, he held leadership positions across sectors: education, development, health, nutrition, child development, food and agriculture, and industry, including as Commissioner of Schools and Secretary of School Education, Karnataka. He is currently a member of the State Education Policy Commission, Government of Karnataka, and has previously served as Chairman of the Government of India Task Force on Early Childhood Care and Education. He's also a trustee of the Karnataka Health Promotion Trust. Thank you, Mr. Kaul, for joining us. Next, we have Dr. Sudha Chandrashekar. Dr. Chandrashekar is a public health expert with extensive experience in health systems, financing, and policy implementation at both national and international levels. She is the former Executive Director, Health Policy and Hospital Engagement at the National Health Authority, Government of India. She was also the Director, Medical Suvarna Arogya Suraksha Trust, Department of Health and Family Welfare, Government of Karnataka. She currently works as an advisor for the Health System Transformation Platform and is a senior consultant for World Bank, India, and Ghana. Thank you, Dr. Chandrashekar. The opening remarks for today's event will be delivered by Dr. Laveesh Bhandari, who, as you all know, is the President and Senior Fellow at CSEP. Dr. Bhandari has published widely on subjects related to sustainable livelihoods, industrial, economic, and social reforms in India, economic geography, and financial inclusion. For the closing remarks, we're joined by Ms. Sandhya Venkateswaran, Senior Fellow at CSEP. She leads the human development work at CSEP with a specific focus on health policy. Over the last 2 decades, she has worked on a range of policy issues, developing and leading the policy and advocacy portfolios in organizations such as the Bill and Melinda Gates Foundation, the Global Alliance for Improved Nutrition, and CARE. She is currently a member of the Lancet Citizens Commission on Reimagining India's Health System. I would now like to invite Dr. Bhandari to deliver the opening remarks. Thank you.
Thank you. Welcome. It's indeed a great pleasure to have all of you here, and especially when we are discussing a work which is in an area very close to my heart. Priyadarshini gave me a whole, speaking points which I'm supposed to speak on, and of course I'm not going to talk about those, but I will still start with the questions that you pose, right? So this work is going to be about, or is about, the key initiatives that need to be taken that focus on the overall primary health and elementary education system. What kinds of ground level issues in the working of UPHCs or urban primary health centers and schools do they focus on? So essentially, it's looking at the interaction between the ground level forces and whatever the policy initiatives are. And in that sense, it tries to capture, and I think it does it very convincingly. In a sense, the DNA of the policy making process, at the ground level, not at the top level, right? And that to me has always been a fascinating area. And the reason is, I've never really understood, perhaps all of us don't really understand why in India systems don't self-correct. You have to get outsiders to come in and say, this is wrong, that is wrong, etc. When everyone in the system knows that is wrong, right? But somehow, external people rarely bring anything new in the system, or people in the system know it. But somehow the systems are unable to self-correct. And to me, it has always been an issue of obviously the ground level politics. Somehow, whatever is happening there is unable to percolate up the system. Now, again, it's fairly well known that to get systems to change, you need to have some outside forces because there are a lot of internal forces that tend to straitjacket many of these. So what are those external forces that need to be brought in? I think is the larger policy question that we need to look at. The mistake that I think social science has made in India is that the external interventions of change that we talk about are still top to top down. They are not bringing in the local politics into the equation. And as a consequence of that, every time you want change, you have to have top-down change. You can never have systemic change, really. So I think that is the issue. And I'll just give one example of this. I was unfortunately involved in a study which compared municipal schools with state schools, with private schools. And it was the municipal schools which were by far the worst performing, right? Essentially, it's the failure of local governance. Now, given the fact that local governance is failing, how else are you going to bring about a system of public education which is not necessarily top down? I think that is a larger issue that we are all grappling with. And that this study also grapples with in many different ways. And this is not just about education or, for that matter, health. I mean, it's also about agriculture. It's also about urban issues. It's going to be about environment. It's generally this whole issue of how do you deliver services in a mechanism which is far more inclusive and democratic than what we have. So with that, thank you everyone for being here. And I really look forward to this discussion. Thanks.
Great. Welcome, everyone. I think I need the remote to change. Yeah, found it. Thing. Yeah. Welcome, everyone, for this evening's seminar. And today I'm going to be speaking about the drivers of primary healthcare and elementary education for urban Karnataka over the last decade. As Laveesh has mentioned, and you may have read in the abstract as well, this study essentially is about drivers. It's about what are the pathways through which policy gets made. It's not really as much about outcomes. Why does a government school perform poorly learning outcomes versus a private school? Or why do government hospitals don't function as well? It's really about what are the actors, what are the contexts, what are the impetus through which policy comes in being in the very first place. And the story that I'm going to tell you about of Karnataka is not a story of unprecedented, unknown health and education challenges. Most of us have heard these stories, heard about these initiatives, these policy problems across our career. But what today I'm going to bring to light is how this story of averages, of average performance comes into being because of the certain nature of policy pathways and policy drivers. But also within it, how it encapsulates a potential for national leadership that Karnataka is very well poised to take on. So very quickly, the Karnataka story is part of a larger 3-state study that we are doing, which looks at drivers of state-level initiatives. The broader research question is why and when does a state undertake new initiatives for urban primary care and elementary education? The focus is on health and education, foundations of that, which is primary care and elementary education. These are very difficult sectors to work in. They have the highest footfall on the ground. They engage with the society a lot, which is why I've chosen to examine pathways here and on the urban context. The urban problem has in some ways remained in the policy shadows. Rural has somehow managed to get a little bit more of attention, and hence tracing policy pathways for urban was a particularly important area of inquiry. The 3 states are Karnataka, Rajasthan, and Orissa, and we've selected these states keeping in mind a particular combination of political regime, economic affluence, and health and education outcomes. And what we focus here on is really states' own initiatives. When the state puts its own money, either its own ideas or its own prioritization of problems. I'm happy to speak more about the methods used in the study if it's of interest, but essentially this is a qualitative study. We relied on key informant interviews across various categories of people involved in policymaking, bureaucracy, civil society leaders, journalists, NGOs, researchers, academics, and a very thorough review of government documents to identify what the key initiatives are. We deliberately went below the state level to two urban constituencies, one that performs better than the state average and one that performs lower than the state average, and traced the policy pathway from the facility level, so your school, right up to the state bureaucracy in health and education. The initiatives that we selected, over a 10-year period, a state will undertake tens of initiatives. The initiatives that we selected were essentially the ones that have the ambition for solving systemic problems. This is not a judgment on which initiative was more reform oriented or not. Did it have the ambition to look at the school and the health system as a whole? So, what does the Karnataka story tell us? When I first started this study, I was asked, why Karnataka? Who goes to Karnataka? It's well-known, rich state with progressive outcomes. It's third highest per capita income in the country, widely placed in whole variety of government documents, national level indices. But as I started researching this state, I realized that actually on many indicators that don't get that much of visibility in national level documents, its performance is somewhat lagging. There are stark intrastate state disparities, and there are issues around access as well as outcomes. So what I did was that I tabulated the outcomes into four broad categories. There are those that we often hear about, very commonly in the case of Karnataka, ones that perform better than the national average, your under 5 mortality rate, your performance in maths in NAS survey. And then there were those that are marginally better than national average. But there are two other sets that I discovered that were better than the national average, but in Karnataka's own performance had declined over the years, sex ratio at birth being one of them, and an entire state where the performance is worse than national average. And what was particularly troubling, that in a state like Karnataka, there are stark intrastate disparities. To give you an example, immunization, which has remained a policy focus for a really long time, the state average is 84%. But in a district like Bangalore, which is right at the heart of the state's imagination of success and achievement, the immunization rate is 78%. There are deficits in facilities. UPHC deficit is concentrated in the affluent South Karnataka. Of the total 51% primary care facility deficit in both rural and urban areas, 54% is concentrated in South Karnataka. Even the uptake of some of these facilities is lacking. It is higher than national average, but for a rich, progressive state, it is lacking. So, in the case of Karnataka, the research question changed. What my imagination was that instead of looking for drivers of state-level initiatives in a rich and socially strong state, potentially a national leader, a state which I think is perhaps the best state to do research in, it turned to looking at drivers of state-level initiatives in a rich state, but socially lacking, but with potential for national level leadership. Okay. So coming to the initiatives of the state. Overall, for urban elementary education and urban primary care, the state has not seen as much of policy thinking activity. In elementary education, there are more initiatives than primary care. There are 14, but of all these initiatives, the ones that take a system-focused approach, that look at the whole elementary education system, there are actually only two initiatives: Karnataka Public Schools and the State Education Policy Commission. Karnataka Public School are essentially a school complex creation initiative where schools with low enrollment are linked with a school nearby which has better enrollment, provided English medium of instruction, pre-primary classes, and also additional funding in certain cases. The State Education Policy Commission and Mr. Sanjay Kaul, who's on the panel today, is a member of the commission, is a work in progress. It's yet to submit its report, so we have to see how the findings will be implemented. But a whole host of other initiatives look at actually very small problems of the education system. In primary health, overall health, there are 11 initiatives, but primary health, there were only 2. Both focus on urban, and both actually are a result of the policy push from the central government as part of the 15th Finance Commission. Namma clinics, which are extension clinics to urban primary care centers, and Ayushmati clinics, which are women's wellness initiatives located within select urban primary care centers. They don't even apply to all primary care centers. The focus of the state has been on insurance and a variety of other policy solutions such as referral transport. Of course, Karnataka is one of the leaders in thinking about insurance-based solutions. Its own state program on insurance also includes certain primary care procedures, but overall on urban primary care, it has only 2 initiatives over the last 10 years. These initiatives, both in health and education, have focused on big challenge of low and declining uptake of government facilities. Karnataka has higher than the national average share of enrollments in private schools in class 1. Both the study sites where we went in the north and south, more than 50% of kids were going in private schools. And the number of private schools is actually much lower than government schools. Still, the enrollment share was much higher. Karnataka overall has the 4th highest number of private schools in the country, and also a very high state of privatization. The use of private hospitals, according to NFHS 5 now, stands at 40%. And as we all know, in urban areas, there is a high amount of bypassing of urban primary care system towards hospital-based care. So this also indicates a high use of hospitals for availing primary care facilities. The policy solution for this larger challenge is to rationalize, consolidate, and streamline. In the case of elementary education, we have KPS, which is a school complex idea. In primary care, if you remove Ayushmati clinics and Namma clinics, there are no other big initiatives. And in the conversation with state bureaucracy and other levels of bureaucracy, I was told the focus is on rationalizing PHCs. The explanation given is, well, the PHC problem largely is in North Karnataka. The rest of the Karnataka state does not have a problem of PHC. North Karnataka, which is like your Rajasthan, I'm from Rajasthan, the comment used to feel a little bad. The rest of Karnataka actually has excess of PHCs in schools. And the reason given for that was politics, that there has been an indiscriminate opening of PHCs, which now can't be shut down, even though they are not being used. And similarly for schools opened under the Sarva Shiksha Abhiyan. There was a recognition that you need more money to strengthen the system, but this is a government system, so you cannot get any more money. So initiatives necessarily have to operate in a landscape of low fund availability. But when I moved away from the state level and went down to the facility level, I realized that there are an entire host of uptake impacting challenges, and I call these as the small challenges, and they cut across various categories. UPHC deficit, Karnataka stands at a deficit of 39% of urban primary care centers. Within schools in urban areas, there is a challenge of infrastructure, human resource shortages, so staff shortages, both of teachers, medical officers, and alignment of staff members with the service requirements in primary care with the user population. Particularly challenging was the fact that a lot of human resource staffing was not done in a predictable, expected, regular manner, which created at times reduce the capacities of your headmasters and your medical officers at PHCs to respond to user needs in urban areas. So for example, if there is a high influx of migrant population, there was not much a medical officer could do, because there wasn't a regular system through which you could raise requests and those requests are fulfilled in the right amount of time. Governance challenges, again, this links with human resources. Responsiveness to user needs was very weak, and even in schools and primary care centers where there were no vacancies, the adequacy of posts and facilities with the needs of the population and the services that they're supposed to provide was oftentimes misaligned. Along with this, regulation and licensing of private sector actors, schools and clinics was weak. So you have another option available for people in urban areas, and hence they are oftentimes choosing those, which creates somewhat of a vicious cycle. You have low uptake of government facilities, hence there goes low funding. And when there is low funding, it further drives people away to private options. And a more somewhat complicated problem is of access. Urban primary care centers in Karnataka don't open after 4:30 p.m. So if you're catering to urban poor, they are not going to be taking medical facilities during peak working hours. These are daily wage laborers. In education, the lack of English medium of instruction effectively made government schools a very difficult option for people to take, simply because there is an aspirational norm attached to sending your kids to English medium schools. So in conclusion, you have this set of uptake impacting challenges that were felt and recognized by the actual facility users and facility operators. And on the other hand, you have challenges that define initiatives, and there is a split between these two. So what drove Karnataka state level initiatives? What has driven this prioritization of certain problems, prioritization of certain kinds of solutions? I categorize the drivers in three buckets. One is the stakeholders, the people in the room, the incentive, where did the push come from, and what was the context. So the stakeholders primarily during this 10-year period have been senior state level bureaucrats and political leaders. It is not that there are not other actors within the bureaucracy in health and education, but in terms of identifying the problems, proposing solution ideas, translating problems and solutions into actionable programs, these decisions are essentially taken by your senior leaders, Chief Minister's office, health and education secretary level people. The incentive for a lot of these initiatives is coming from a central government push. As we saw, 15 Finance Commission is funding Nama clinics and Ayushmati clinics that kind of provided the push for the state government to invest in these areas. And for education, the idea of school complexes as an answer to problems around enrollment and uptake has been discussed in a whole variety of government policy documents, Sarva Shiksha Abhiyan, National Education Policy, including the more recent one. But where I find the Karnataka case to be particularly interesting is the context in which policy is being made. It is what I call as the local policy context. This is different from the local context. Your local context could include, for example, income disparities between a Bangalore and non-Bangalore area. Local context could include high migrant population in areas like Belgaum, which are somewhat industrialized. The local policy contexts are those aspects that influence policy. So there are four components to this. Every new initiative or policy solution has to meet these four areas of the local policy context in Karnataka. First is that new ideas, initiative solutions should not have financial implications. There seems to be, from the state bureaucracy level right down to the facility level, your school teachers, your medical officers, who have accepted the fact that we cannot increase budgets. We cannot have initiatives that come at the cost of enhancing the financial envelope available at the state level. The second is that the challenges that make it to initiative level thinking have to be commonly understood. Nobody will disagree that low enrollment is a problem in government schools. Nobody will disagree that in urban areas, people bypass urban primary care centers and go to hospitals, and something needs to be done about. These are non-controversial things. And essentially, challenges tend to focus on this. And the solutions are ones that are visible and understandable solutions. So anything that could, for example, issues around teacher training. For example, issues around whether government initiatives should focus on English medium of instruction in government schools, which are very polarizing problems. These somehow did not receive as much of attention in policy initiatives. And lastly, policy interventions have to have somewhat of a political utility. A Karnataka public school is a flagship program. Every single time a new KPS is opened or a school is recommended to become a KPS, this is done on the recommendation of the local MLA. And they end up becoming as things that the local political leadership has of its own will done for the constituency or of the state. So these four conditions have to be met in the current policy thinking, policy initiative scenario in Karnataka. Of course, there are other pathways through which policy gets made. And I identified four of them, and these seem to be fractured and weak. First, the internal bureaucratic system. From the grassroots right up to the state level, as in every state, in every bureaucracy, there are regular movements of information, challenging knowledge. But at the state level, it's aggregation and consolidation into a defined agenda. And the translation of the agenda into initiatives is somewhat weak. When the initiative is formed, when it becomes implementable idea, how it becomes implementable idea are not necessarily decisions taken by experts within the education bureaucracy. It's decisions that are taken at the senior bureaucracy level involving other members of the larger state bureaucracy, such as finance and chief secretary level people. You also have, Karnataka has a very active civil society and very strong private and professional bodies. And these do work actively with the government. However, the challenge is that they have to work within the agenda that has already been set, firstly. And secondly, within pathways that are not necessarily open to everybody. Not every civil society organization is going to have access to senior state bureaucracy and political leaders to design and implement these programs. And that has implications for what kind of ideas get into the room and get implemented. Social movements. Despite having a whole variety of social movements on farmer issues, identity issues, language issues, the mobilizational energy has not translated into examining what does lack of access to good schools and good medical facilities does for the identity of the communities and people. To give you an example, Belgaum has had an identity language-based movement since decades now. The only point at which that movement has looked at education is the medium of instruction. It hasn't spilled over into looking at other dimensions of government school performance that can act as a pressure group or a source of idea or a source of accountability for what's happening at the grassroots level. And lastly, inputs from local political leaders and electoral pressures. Now I want to spend some time on this. Formally, political leaders have no role in the everyday functioning of the school and the health system. Yeah. Political leaders are not accountable for what's happening as far as enrollments, what's happening as far as outcomes, etc. But your local MLA is essentially the patriarch of the constituency. So where your school is opening, whether your teachers are getting transferred, whether there are available government lands that can be translated into opening a new number clinic or a urban primary care centers are essentially decisions taken by political leaders. But this has not translated into an ownership for social welfare. The role of political leaders at the grassroots remains individualistic, transactional, and episodic. People will petition their local leader. हमारे स्कूल में टीचर नहीं है. Our UPHC is not functioning properly. Can you move the UPHC from a rented building to an old building? But this does not mean that come elections or even non-election forms of political mobilization, the functioning of the system is in some way connected to a political leader's career. The structure of politics at the constituency level is such that the neta is seen as doing charity for the people when they open a new school or they open a primary care center. It is seen as a part of their political brand building, not a part of their responsibilities. So consolidation of political will for systemic change is very weak. And also there is a legitimacy crisis. A lot of the local leaders run schools and medical establishments. And the problem with that is that then the trust factor that the leader is invested in strengthening the government system is somewhat weak. And elections are not prominent in changing the structure of politics. In fact, it reinforces this trend that somehow the local leader's responsibility for schools and health facilities is just organizing annual events, organizing sports facilities, participating in health campaigns and drives, and that's it. Can we change the drivers? How can we think about, in some ways, ensuring diverse set of policy problems making into the rooms and diverse set of policy solutions? I think the very first thing that we need to create is to create an actual link between social welfare, health and education outcomes, and political performance. So one of the suggestions that we have is to create constituency profile at the assembly level, not at the parliament level. An MP's job is not as much engaged with the nitty-gritties of everyday politics. The second, and this is somewhat of a difficult pill to swallow, is to promote a public orientation of elementary education and primary care facilities. So one of the things that I heard from the non-poor among the interviewees that I spoke is that, well, actually, you know what? The money is coming from our taxes, yet we are not benefiting from it. So why should we care what is happening here? And that in some way creates a legitimacy for why private sector perhaps needs to be strengthened. For this, I recommend that we should have a diversity index. In the catchment area, in urban areas, there is always a diversity of population. There are those who are urban poor and those who are not. in well-functioning urban primary care centers, and this is something I've witnessed in Karnataka, where the medical officer is engaged, where it is fully staffed, there are drugs and tests available, there is an engagement by the non-poor as well. So just as we have a whole variety of indices, we should also have an index that marks what is the uptake of the non-poor for every single such facility in a particular education/health district. This will also create a visibility and pressure on the state leadership to provide better facilities for schools and UPHCs in order for improved uptake. The next one is, again, it would seem somewhat of a repetition that we all know that investing in health and education contributes to economic growth. But my argument here is for the government to set up a commission for a study on how the importance of health and education is not just some long-term thing that will happen for our grandchildren when the economy will be really great, and that will prevent people from destitution. That investing in health and education benefits me as an individual by helping me save, by helping me become rich, by helping me get stability in my household. There is an aspirational value for public systems in places like Karnataka. And it's the reason why I think many of us here should be using government-run education and health facilities. And lastly, we need to strengthen non-bureaucratic channels for initiative making. There are two things I suggest here. Karnataka is a land of expert commissions and reports. These need to be made visible. And while there is always a doubt about who really reads these reports and who really knows what somebody says, they don't know it is because it's not disseminated. But where they are disseminated, they do become a part of forming of political agenda. So for example, the committee that was formed in the early 2000s for additional funding for the most backward talukas in Karnataka was repeated to me over and over again as the benchmark that has to be achieved. Did it get actioned? Not fully. Did it achieve its outcome? Also not fully, but it set the benchmark in the conversations for how health systems have to perform. And lastly, we need more formal channels for new initiatives. We need advisory bodies that have representation from across stakeholders who have the power and the funding to propose new initiatives. It's up to the government whether they agree or not. But the process of thinking about problems, how do you prioritize the challenge between training teachers to teach better English versus training teachers in a more inclusive pedagogy that reaches the maximum section of people in their constituency. These are strategic calls that need to be made, and initiatives need to be made around that. So lastly, why and when did Karnataka undertake new initiatives for urban primary care and elementary education over the last decade? I argue that this has largely happened at a top state level in response to a national level policy impetus and a local policy context that has been very restrictive. Karnataka can definitely do better, and here's hoping that it does. Thank you.
Thank you so much, Priyadarshini, for that. I'm sure there are a lot of questions. Again, for those who are joining us on Zoom, please feel free to post your questions on the chat. Before we go to that, I'd like to invite Dr. Sudha Chandrashekar to give her comments and remarks.
It's on. Okay. Hello. It's clear. Okay. Thanks, Priyadarshini. I think it was a very comprehensive feedback from your study that you gave. I think there are some of the things that has been happening, as you say, but there are also certain things which start but doesn't go all the way. That is also the problem with policies. Is it not just formulating something, but also looking at getting it implemented to the fullest extent and sustaining it. So that would be a very critical factor when we look back on what are the initiatives that are started, but also which are the ones which started but did not go through. Maybe that is why you're not hearing about it, because it did not create that kind of an impact, but there were initiatives that happened, but did not see it sustained. So that will be one of the issues in any state, for example, for that. I think issues that you bring out of why it is not, I'll limit myself to the health sector, and Sanjay sir would speak more about the education. So within the health sector, what I feel is that, especially urban health, everyone speaks about it because more than 50% of the population is now will live in the urban areas. But the kind of the rapid transit hasn't made the same level of effort from the government and the state to make sure that we are prepared for it, because the kind of influx that comes into the urban area, sometimes it is quite sudden, especially as within Karnataka, I'm sure the Bangalore, with just the IT boom that happened in the 90s, the kind of influx that it came, becoming a retirement paradise to a booming young crowded city, is quite sudden. And things didn't change at the same pace at the health system level. So that is why it doesn't match up with what expectations or what the population demands also. And it's not just about the high-class migrants who come into Bangalore, because the moment you get these kind of employees, then you have to have their supporting structures that they influx for the cooks, the maids, all coming in, cleaners who are coming into the system. But they are all coming in not only from within our own intra-state, but they're also coming in from other state, because the border districts, they get more opportunities here to survive. So we need to be ready, and that is one area of especially urban health we are currently not working on how do we reach out to these influx of migrants. So last year when I was in Thailand, I visited their whole migrant program. The way they are very structured, from the time they enter, any migrant enters into the city or starts settling down in terms of accessing any kind of service, at that point in he is asked for registration. Have you registered in the migrant counter, where they have set up specific counters where all details about who's coming in, his family, whether they're vaccinated, whether they have any health problems, everything, and they're tied to the nearest health facility, which are free and they can access it. So I think that kind of a structured process needs to be looked into for health. And as I said, when they look at families, they also look at whether schooling, whether your children are enrolled somewhere, or can you, or they give you details about the place where they can go. So in that sense, I think that is one of the initiative I'm quite passionate about, and to see it happen actually within the, as a part of the city action plan. Currently, we are working with 3 cities in terms of Bangalore, Bhubaneswar, and Bhopal as a part of a healthy city concept. I think those are the elements that we want to bring in and come up with those kind of things for the government to take up. You know, as we said, policy doesn't happen top down or from anyone else, but it comes with an idea, and comes with some push that, repeatedly we showcase and get things done. So I think those are initiatives that we can work on. We have to not just limit to identifying the problems, but also look at how we can make those solutions to the government which are feasible and they can scale it up. I wouldn't want to limit to few cities or something. Okay, we did that, that's enough. But the government has to work on, and you have to advocate for it. That was something, we need to keep on ensuring that they take it up as their own policy. So that was specifically with regarding to the migrant. With regarding to the private sector, as you said, with the kind of influx, I'm sure our public system will not be able to cater. They will have to reach out to some health facility for their routine problems, and they would end up with private facilities, which is there every nook and corner of the city. So that is again both a boon, because you can tap into it. We did that for the HIV program, wherein the private clinics and the preferred providers of the vulnerable population used to go were identified, and they were asked to reimbursed at a particular rate so that they could take the services from nearby. So the private provider shouldn't be thought of as competition or to the public sector, but complementing the public sector till, we will not any day be able to provide that kind of a level of care to everybody free of cost. So there will be something where we can work out a capitation model or that kind of a system wherein these urban populations have to be mapped first. Many times, if you look at the DHO, he doesn't even know exactly how many people are there, what is my actual vulnerable population. You don't have to work with everybody in the urban areas, because the higher level class people, they will have access, they will have their own system. But the vulnerable, the urban poor, is one section where we need to look at a little bit more and solve their issues first, and then maybe scale it up to the next other APL populations. But you have to come up with that kind of focused initiatives that needs to be done across. In terms of your alignment with the center state, I think I would say that there are initiatives which states have developed and center would have taken it up, but may not have given due credit to the states. So that is also happens, and it looks as if it's a centrally sponsored or centrally initiated program. I would definitely put on record that the Ayushman Bharat scheme, which is actually launched, which includes both primary care and the secondary and tertiary level care, which was actually piloted first for a group of people in Andhra Pradesh, the undivided one, taken up by Karnataka, worked up a little bit more, made it into a UHC, and launched much ahead in March 2018 than the later, which came in September 2018. But everyone speaks about Ayushman Bharat, not about the Arogya Karnataka, which was the first UHC state to come up with that idea. So I would say that there are initiatives which are done by the state also, but it may lose because of the state central difference in government or other kind of issues that they might have. So that is definitely a point. And another thing is the urban health is not just health department. So don't limit even your research. I would say that you have limited yourself to the health department as the respondents. So I think it has to go beyond health, beyond health department, because there are many, many factors that are involved, including sanitation, the municipality commission, and, the local governance, wherein they have to also have a important role in maintaining the health of the population. So in that way, I think there is a scope for usage of the smart city concept, especially in the 100 cities that come up every year as smart cities. There is a provision for including health as one of the key element into the smart city projects. And also moving beyond smart city, I think we would like to advocate for healthy city. And Bhopal Healthy City is one of the first initiative by the MP government also to take it forward as the move towards healthy city, and wherein the district collector is the main key person driving those activities, and he is able to bring in all sectors together and initiate the program. It is still a work in progress, but that is an area where the social determinants of health needs to be also incorporated to ensure the health of the population. So we can't just limit to the health department's initiatives. And also, when we look at intersectoral, I think there is a lot of scope for the National Urban Livelihood Mission. We are still testing that model wherein we can involve the SHGs. SHGs have been involved for many activities, but for health, they have been involved much lesser. But we are looking at how do we involve them, because they meet every week, every month for their microfinance initiative. But how do we give them a small capsule of a health information or a health dissemination, social security schemes available for health, so that they can disseminate it within their group. And if they have a pregnant woman or a child within their group, they will take in those initiatives further. So I think that those are other social groups that we need to strengthen beyond the mass, which is the Mahila Arogya Samitis, which I'm sure wherever you go, it is half on paper, half dysfunctional, and very few active. So we need to look at strengthening those initiatives, but also looking at which are the other groups. How do we engage the community better with, further engagement of the citizens themselves to promote their own personal health? I think that is, again, another dimension we have to go. Government cannot do everything. I'm not stopping that, not trying to defend the government, but also looking at that there is a limit to health, wherein beyond government, I think it is our own discipline, self-discipline about our nutrition, our healthy living habits and style that will also needs to be promoted, especially in the urban sector, like the Fit India, the marathon. There are so many initiatives that come in terms of, that also engages the citizens better and making sure that they work in a much more a stronger way would be this one. How much time do I have? If I have to, yeah. I think I can stop here and then we can have some comments from sir and then we can come back for more comments. Yes, sir. Over to you. Yes,
sure.
Mute it, right? We can mute this.
Thank you, friends. Let me begin by saying that Priyadarshini study is very valuable because to my mind, there's very minimal literature on drivers. Policy advocates like us, CSEP perhaps also, keep on talking about how it's important to focus on education and health, what good initiatives are there. But what actually drives initiatives and what drives decision making is one of the first few studies that I've come across. So congratulations, Priyadarshini. And the harsh reality is that even when we make out a case for sound and rational decisions in areas, the social sector, there is very little action that takes place, either in the political class or the bureaucracy. I, of course, was particularly happy because I spent about 2 decades in Karnataka and about a decade in health and education sector. So when Priyadarshini asked me to engage in the study, I was quite delighted. So I think Priyadarshini did talk about why budgets are not an issue in Karnataka and all decisions are based on operational efficiency. And here we have to recognize that most state government's fiscal space is limited. And Karnataka in more recent months, because of these 5 guarantees, which takes up about 50,000 crores annually, leaves very little space for sectors to get enhanced allocations. There's also an important recommendation that Priyadarshini has written in a paper, which she didn't talk about too much, and that is that these initiatives will come to fruition if and when the non-poor begin accessing these services. Now, I think this is also a very important recommendation because we must recognize that those of us who are engaged with civil society feel that we'll mobilize from the bottom up. Please recognize that the poor are so engaged with day-to-day survival and issues that to expect that they will mobilize and ask for better services would be a fantasy. So therefore, getting the non-poor to come to schools or access health services will become a major driver. And I think it's an important recommendation that she's made. That also explains why certain services get more attention. For instance, a good road network, water supply, electricity for the village. These impact more directly the non-poor. And that's why you will find much greater impetus or push from the political class for services which non-poor also become stakeholders. So therefore, the recommendation that PHCs should become, the middle class should become a stakeholder in the primary health sector is important. And similarly, the recommendation that Priyadarshini makes about a diversity index. But unfortunately, in the health sector, the harsh reality is, forget about the poor, non-poor, even the poor do not really feel that in many cases, the health system is the first port of call. In most villages, there are 2 local health providers. And despite the change because of ASHA workers, even today, the first port of call for the poor is not the ASHA worker or the ANM, but the local health provider. So this is the actual ground reality. And that is what explains what Priyadarshini's paper talks about, the very significant out-of-pocket expenditure on health, even by poor households. Karnataka, of course, Priyadarshini talks about being a prosperous state and having a highest per capita income. But it's also a state with the largest or most severe inequalities. So Bangalore alone, as a district, occupies 30% of the state GDP of Karnataka. So take out Bangalore, and you really become on par with one of the backward regions of the country. And there's districts in Karnataka which are as poor as Bihar, Odisha, or Rajasthan. And that is the reality. So really speaking, this view that Karnataka is a rich state is really not true. And that is also explains why health education indicators in Karnataka historically have remained. Now, briefly, if I could turn to complement or supplement what Sudha talked about, the whole area of primary health centers, which is the focus of Priyadarshini's paper, this is a pattern across the country that levels of utilization of PHCs have been abysmally poor. And the root of the problem is in the design of the PHC. The PHC is done like a Sarkari office. It's not a healthcare system which is available 24/7. And Priyadarshini talked about the 4:30 time limit. Even in the rural PHCs closed down at 5 o'clock. So though a PHC has 4 maternity wards, you cannot predict that delivery will take 10 and 5. And a simple solution of putting a staff nurse available at night is not something which is really driven, at least in Karnataka. You don't require a doctor to do normal deliveries. So therefore, institutional deliveries take place in private facilities. ANMs were designed to do deliveries at the subcenter level. That's why they're called auxiliary nurse midwives. So some places the ANMs in Karnataka do deliveries at home, but the subcenter was certainly not equipped to do deliveries. On the urban PHC, which is again the focus, there is an institutional structure governance problem. Part of it is the 74th Amendment, which provided adequate resources to rural areas, but very few fiscal support to urban municipal corporations. So the district health machinery is a Zilla Panchayat. There is no counterpart in the urban areas for the health department. So where is the push going to come to set up an urban PHC? Yes, there is the Government of India initiative, but who's going to manage that PHC? Who's going to provide that supplementary support of diagnostic equipment or provision of infrastructure? So that is a huge lacuna in the urban health system. And fortunately, as with migration that Sudha talked about, you're going to see a huge vacuum. The levels of poor quality do not end with the primary health center. As you go up to the community health centers and Taluk Hospital, which is supposed to be the first level referral, you have shortages of infrastructure in terms of manning, staff, diagnostic equipment. So therefore, you really do not have much drivers. Now, when I was in Karnataka, fortunately, the bureaucracy had been able to negotiate a fairly sizable World Bank project for revamping the community level CHCs and taluk hospitals. And the political masters saw that, these hospitals had beautiful landscape, beautiful infrastructure, brand new X-ray machines. So they became popular, and there was a big push at the political level to ask that their hospital should also be included. But in the absence of such initiatives or funding like a World Bank, you really don't have local drivers. But as between primary and curative, at least at the central level, there seems to be much greater push for high-level curative services. So therefore, you don't talk about community health hospital, but you talk of AIMS. This is more fanciful. So 17 new AIMS, bypassing referral systems at the primary have come up. And 90% of patients should not be going to AIMS. But it's certainly more popular, easy to sell politically. And it is only sometimes when you have catastrophes that some good initiatives take place in the health system. For instance, COVID-19, the much neglected disease surveillance system came into importance. So you require a Surat pandemic to take care of sanitation. You require a COVID to take care of certain initiatives which are sound. Now, that may not be the best way of drivers, but this is a reality. Now, the Ayushman Bharat, of course, Karnataka has been a pioneer, but it's also led to a major crisis which is taking place in Karnataka because they talked about a widened health coverage. So you have 85% of the population which is supposed to be part of the Ayushman card eligibility. The government of India funds 40%. So we are finding that as the scheme becomes popular, a lot of your health resources are going to get diverted into this purchasing of facilities from the private sector. Now, is that a good thing for the Ayushman Bharat thing? Maybe not. And the bureaucracy has tried to control it by saying you cannot automatically go to a empaneled private health facility. We will reserve certain facilities for government hospitals. It's only when there is no such service available can you access. So the bureaucracy is finding ways of containing the damage. 5 minutes on education. The paper has spoken about the Karnataka Public School Initiative. Now, the drivers have not been just the government of India and the school complex. There have been several drivers. And now the cabinet has taken a decision. The paper talks about 200 schools. Actually, the cabinet has decided to take up 5,000 KBS schools. There are 3 drivers. One is the existential crisis that the school education systems face, not only in Karnataka, but in large parts of the country, that children are not coming to the government schools. Even the poor households, the moment that income thresholds go up, they shift to a private school. The second is a mindset across the population, at least in South India, that you must access an English medium school. And the third driver was that the initial shift was taking place from Anganwadis. And since you did not have a Montessori or a nursery school in Karnataka, they were shifting at the age of 4 and 5. So the KPS, therefore, talks about an English medium school from class 1. It talks of a nursery from the age of 4. And it talks of an integrated school complex with improved infrastructure. And the KPS actually has been able to get, within the limitations, some enhanced budgets. And this is a kind of initiative which has seen complete alignment between the bureaucracy and the politicians. The Education Commission, we have been trying to engage with them that pedagogically, classes 1 to 5, you should have Kannada as the medium, can introduce English, but it's not happening. So they want to announce that this is an English medium school. Well, forget about the quality of English teaching, which Priyadarshini says is equally important, but the announcement, because they feel that it will stem this tide of shift to the government schools. So because of these limited budgets, the bureaucracy finds initiatives which are sound but compromises. For instance, Karnataka's education system suffers a huge shortage of teachers. So what has Karnataka done? They have announced appointment of teachers, but on a contractual basis. And why contractual? Because you pay them 10,000 against about 35,000, which a regular teacher would do. So the finance push or limitation, so you can appoint 10,000 contract teachers at the same budget of, say, 3,000 regular teachers. So you can fill up vacancies at 1/3 of the cost. Now, the Education Commission, which I'm part of, was really not a local initiative. It was in response to the national education policy. We have a Congress government. We said we must have our own policy. We do not accept the NEP 20. So that was it, right? There is, of course, a huge abject neglect of the high school system in Karnataka, but there's not much driver, but most MLAs have their own schools and their own health clinics as well. So there is a conflict that the MLAs face. So in conclusion, My own candid view is that the economic rationale and studies and advisory groups may not be major drivers. And that's where I differ from Priyadarshini's conclusions. There is already a lot of literature on the economic benefits of investments in education and health. Nobody disseminating it is not going to make much difference. So what can become the driver then? If this is not a driver, my own view is that you have to have a marketing pundits of attractive packaging of good initiatives, which have electoral appeal, which are easy for the political class to understand. So, for instance, the driver for insurance was insurance for all rather than only for the BPL. Driver for APS was English medium. And across political lines, English medium is very popular in Karnataka. During my time, there were Kannada activists who said you cannot impose English on the state. All that is gone. MLAs openly talk about English medium. And that's true of Andhra and Telangana as well, which have also introduced English medium. So there's going to be actually a huge dichotomy which what is going to happen in UP and Bihar and what is going to happen in South India. So therefore, initiatives like teacher education will never find a place, never become a driver, but English medium will catch the fancy. So therefore, should we create, identify initiatives which are going to be sound, be attractively packaged, which have electoral appeal, both at the local ground level as well as the political class and the bureaucracy. I think that is a challenge that civil society advocates and economic pundits should have. In Karnataka, there is a positive opportunity because most secretaries in education and health have been really competent officers. There is a political sensitivity that these are two large sectors where you can't mess around too much. So at least outwardly corrupt officers have not been posted there. There have been reasonably long tenures that have had, and it is for the civil societies to engage with them, package it in a way that can be sellable. So that is what I'd like to conclude with. Thank you, Priyadarshini.
I have time. Just open it down the questions. Okay. I'll add it with some of the response. Hello?
We'd like to just open for audience questions. We have participants joining us. So, yeah. Okay. We'll start with Amarjeet. Thank you so much.
Thank you very much. Thank you very much for that presentation. It was a very balanced panel. You had your critiques of what doesn't work in Karnataka, and we had two defendants from Karnataka sharing with us all that has happened there. But, the analysis, I have no quarrels with the conclusions. My only suggestion, by way of building up the arguments more forcefully, there are a few things that on Karnataka is paradoxical. I agree with you. Yeah. But he need not be apologetic about being from Rajasthan. Look at the national achievement studies over the last 10 years. Rajasthan ranks above Karnataka. Why? Among other factors, I'm recently discussing with the Development Commissioner of Karnataka. That's what the data was telling us. Now, the others just left the room. We are in the process of doing our work on prose. One of the very big peculiarities of Karnataka's schooling system is it is the most fragmented schooling system anywhere in the country. 9th and 10th is one school. 11th and 12th is another school. 6th, 7th, 8th is a third school. At every level, it's an independent school. And that has consequences. What Rajasthan said, why does Rajasthan rank in the top? It did something between 2009 and 12 which worked very well, which is the composite school. What Uttar Pradesh is doing now. Within a 500-meter range, there are 8 schools in Uttar Pradesh and Lucknow. 8 to 10 schools. That composite school made a difference. So from the education side in Karnataka, one, I think the composite school, the other is the issue of language politics, as Sir mentioned so strongly, that everyone wants English education, but politics of the state was Kannada must triumph. And there were challenges because of that. The one, of course, in policy, which you rightly mentioned, you've talked about urban areas, and I think we are all responsible for this. Sarva Shiksha Abhiyan, urban was an afterthought. Yes, there was a committee that looked at urban more closely. Rural health even more so. It started only as a national rural health mission. For it to become an urban health mission, there is a document which is still gathering dust. After a lot of consultation with all the states, but all that happened, the name R was dropped. NRHM became NHM, and we said we've done urban health also. No allocation of resources. No additional allocation of resources. The overall kitty increased, but no earmarking of resources for urban. The third point that Sudha rightly mentioned, when you're talking about urban, it's difficult not to look at municipal finances. Because what you are seeing, some of it, might well be the outcome of what is the current situation with municipal finances in many parts of the country. The paradox again, it's about education and health both, and more so in urban. Local governments are supposed to manage this, but the resources for these sectors come from the center and the states. Now this paradox is difficult to manage. So therefore, if you had discussed decentralize and devolution also as an important factor, from the same Karnataka, I'll share two very recent success stories. They have done very well on the public libraries. Why have they done well? For once, they are trusting Gram Panchayats and not the Zilla Parishad. What we take as decentralization in Karnataka stops at district level. We've created a new elite at that level. MLAs, everybody is comfortable with that. Public libraries is the first time when they are actually going down further. And as I mentioned, Karnataka is wanting to learn from Rajasthan. I had the privilege of sending the Rajasthan report to the development commissioner for her to look at it to see exactly how they work on the education side. On the other thing about, I think the point about local livelihood mission, SHGs and all was made. Again, paradoxical. The Mairada program in the old Madras presidency, parts of Karnataka and Tamil Nadu, that's where it all began. C. Rangarajan's famous circular 30 years ago was primarily to cover that. But unfortunately, again, this fragmentation and challenges, do you know that the livelihood mission is not a part of the rural development department in Karnataka? It is a part of a skilling department, for them which there is a separate minister. So it doesn't link as easily as possible. Since you're looking at systems, you need to look at these aspects as well. There are some challenges there, and we have tried at least 3 to 4 chief ministers. Why don't you merge? Why don't you merge? Why are you keeping it separately? But you have to have one minister, so you have to create a portfolio for that minister. So issues of this kind have definitely So panchayats as the prime mover, I would say, is a very important point. Some of these other, the composite school is a point that I made. Financing, you need to politics of language. Decentralization deserves more attention in an analysis of Karnataka. Because I think we have this false sense of thing that, Karnataka is the leader. Did this, did that. But the reality of that decentralization is very different on the ground. And when they start trusting local institutions, they do much better.
Okay. Thank you so much. Other questions? I think we'll start there.
Hi, everyone. First of all, thank you for the presentation. Okay. Yeah. So my name is Arman Chaudhary. I'm currently working at JPAL South Asia, again on a urban health project in Uttar Pradesh. So I thought that this will be a very good introduction for me as a data fellow about urban health. So one thing that we were talking about, I'm hosted at Samyak organization. It works with Collective Good Foundation. So one thing that we are still figuring out is that for the urban health projects or the interventions that we are planning, who should be the target group that we are looking at? Because in the session today itself, in the presentation, we had 2 points. First, that you can't look at everyone in an urban ecosystem like you can do maybe in a rural setting, because there are so many people with so many socio-economical backgrounds, right? Then the idea was that look at the most vulnerable sections. But then a point came up that without including non-poors in this segment, right, you can't really imagine public health infrastructure improving in future. So that's one question that was coming to my mind, that how do you look out for this contradiction? And the last one was that being a data fellow, we are trying to make a decision-making support system as a pilot project in Uttar Pradesh. But what we are missing at is that we don't have data only to start with for urban health. So if you have any insights on that and how we can move forward. Thank you.
So we'll take a couple of questions. I think Avni?
Are comments allowed or only questions?
I think comments if it's very, very brief, sir, so we can get some people on as well.
So the comment was, I think everyone kind of touched upon it, but just it'd be interesting to see the institutional structure of urban governance and get a little bit deeper into it, because I feel like that could be one of the reasons for the drivers that you're seeing. There's a complete vacuum. So I mentioned rural libraries, like Grama Arogya is another great initiative at the rural areas. But there isn't an urban equivalent because of lack of the institutional structure. On a question, so there are policies and then there are good and implementable policies. Of your drivers, which one of these led to, like, do you have a hunch of what are the factors that actually leads to good policies? And that's where I think, so that's point of, is it that when it comes less from a centralized top-down manner, there's something that's more organically grown? Did you get a glimpse or sense of that?
Okay. And we'll take one more. Anyone else? Yeah, sure. Sure.
Yes, hi. I have two small questions. First is, are there, from your study, are there any learnings or suggestions for impact evaluation agencies and research, and how Sir spoke about marketing of certain initiatives and the role that evaluation can play in that. So are there any learnings on that or any comments on that? Second is, the private or the CSR or civil society organization ecosystem within Karnataka, you spoke about how that even that has to function within this certain framework. And there's also not just functioning within that framework, but also there's a lot of CSR initiative, like especially in the Bangalore region. So there's a lot of funds going into schools, for example. But to what extent do they speak to each other? Is there collaboration happening? Is there learning from others? Is there there's something called what is that? Basically, like ek school mein there are multiple agencies creating toilets, right? So there is that sort of getting the word bit. Yeah, like a lot of multiple initiatives within the same school, and how that can what they don't really speak to each other. So are there any learnings or any suggestions on how policy can tackle that?
Well, is that it? Yeah. Okay.
Yeah.
Okay. So I think I'll start with the last one first. So in terms of the CSR funds coming particularly in schools, and multiple initiatives by, I suppose you're talking about NGO initiatives working in. Now, the thing is that there is a perception problem that has created as far as schools are concerned, right? The idea is somehow the government has let go of the education system, and teachers and headmasters are having to go out and raise funds either through CSR or through philanthropic donations in the area. And managing those funds is becoming a challenge at the school level. Right. So instead of the funds being necessarily being a driver in improving either the value of public education or the value of public schools, or, improving the overall functioning of the schools, it is also having this other kind of implication where the impression of the school system is that somehow the government doesn't want to really invest in it. So there is this larger ecosystem that is coming in to provide things, and there is a lot of administrative chaos happening around that at the school level, because oftentimes schools don't have the capacities for accountants, PNs, tracking of funds that are coming. So certain schools end up benefiting from this over others. So within the same government hierarchy of schools, there is a split between the good schools that get funds, and they'll get funds from everywhere. They'll be the good KPS school, they'll also be the good PM Shri school, they'll also be the good CSR school. So what it ends up doing is concentrated capacity building. It doesn't have a spillover effect in the larger system. Your question on evaluation, I was a little unclear of. Of course, there has to be evaluation of the system, and the problem of there not being a mechanism through which users of public facilities, so your parents, your people who go to UPHCs, not being able to tell the facility in charge, the headmaster or the medical officer, and about their challenges to access a certain service, and them being able to solve it. Right, them being accountable for what is happening within their catchment area, because a lot of the control doesn't lie with them, is a big problem. So, the evaluation studies, the evaluation has to happen in a bit more of a cooperative and collegial manner with the government system, but particularly at the local level. It can't be internal to the system where some feedback is being given about facility level actors, and it remains within the system. It doesn't sort of spill out of it. To Avni's questions, firstly, the point about did I have an intuitive sense on which sorts of initiatives become better and are implementable, and whether they are top down or bottom up? I don't actually believe that category is very helpful to understand social welfare initiatives. It doesn't matter whether an initiative is coming from top down. So as Amarjit mentioned, and a lot of us over here have also talked about whether the Karnataka Public School or even the number clinics, by themselves, the initiatives are actually solving a very, very real problem. The challenge is not so much about whether the problem is something that nobody agrees with or the solution is completely, it's the extent to which the solution is actually owned by people who are managing these facilities. And I think when an initiative is seen as solving a problem by the administrator of the facilities, irrespective of whether they mobilized around it and raised it or it came from top down, is when an initiative works. So for example, in the case of Karnataka Public School, I was time and again given the example of KPS as being the example for how you can get the middle classes back into the public system. So where the KPS program was working very well, where trained English-speaking teachers were being provided, where infrastructure upgrades were happening, the program had great success. But the problem is that the solution that was being provided was not applicable to all possible schools that were being considered to become KPS. So somewhere I think the link is, it's not just about that the solution should sound good at the state level, irrespective of where it comes from. But the solution has to have resonance with people who are managing facilities. So intuitively, my sense is that's what works. On the governance challenge, so I briefly do mention it in the paper, that one of the biggest problems that urban primary care centers or even urban schools faces, funds are routed through Zilla Panchayats, not through the municipal corporation. The collector and other actors within urban governance system have no idea what is going on. So, but it's definitely something that can be looked at for a more sort of in-depth examination and subsequent reviews. I think to your question on who should the urban primary care center focus on? So there is a population norm for a UPHC, right? 50,000 people. UPHC does curative, preventive, and promotive. For your preventive and promotive functions, you have to engage with the entire catchment population. It's not just for the poor. So when you run your, malaria drives, or you run a whole host of public health programs, everybody in the catchment area is engaged. The problem is that engagement itself is weak. Curative ke liye, in any case, you need a more sort of legitimacy building for urban primary care centers, but for these other functions, in any case, you're engaging with everybody. So I don't think the question so much is that, we need to rethink who is the person who will engage with the urban primary care center. That point is clear, though under NUHM, UPHCs are supposed to focus on urban poor, but there is a population norm. It's just that you need to strengthen that linkage. So yeah, any other?
Can I just one start? I think Amarjit for school education make an important point of why Karnataka has composite schools. I think just when Rajasthan was able to do this consolidation. So, if you go to the history of what happened, the government of India talked about not of a school which is an integrated school. So you had UP. So you had the DPP with classes 1 to 5. Then you moved to elementary. Secondary school mission started only in 2000. So we lost about 40, 50 years talking of schooling of 4-5 years. And by the time the chappie became adult, he relapsed into illiteracy. So there was a flawed policy, and the KPS has actually talked about this integration, which maybe 10 years after Rajasthan, but this is the way forward. So you have in Karnataka about 3,000 schools with enrollment less than 10, not 10 in each class, collectively 10 in 1 to 4. So this is the challenge. So and with the now large number of vacancies, what kind of quality schooling can you expect? So now they're talking of integrated complexes going from nursery to class 12. So that's the aim of KPS, but at least classes from nursery to class 8 or 9.
Just add to what it's working, right? Okay. Basically, when you're looking at mapping those urban populations, I think the main issue there is that outreach system, the way it's there in the rural system, is not there. Your ASHA worker concept, if you look at even the urban ASHAs, they are not enough to cover the kind of population, because if you say it is a small 1 kilometer radius, but there are 100 flats, I'm not sure whether the ASHA worker can actually go up around looking at, covering and informing everybody of all the initiatives of the UPHC that is happening. So that is also an issue. That is the reason that they are targeting the people who are more accessible. Otherwise, these gated communities will not even let you in. So that is a problem, that they are focused more on the urban poor, where you can actually reach, and maybe because their need may be higher, but it is supposed to be for everybody. But the only way to get more people from the higher upper class is also one of the initiatives, because we are looking at NCDs as a major driver for health now. I think getting some additional services than what you normally do has helped in bringing even the non-poor to come in. Like, for example, we had an initiative in Mysuru where they had started doing diabetic retinopathy screening. The instrument, the technician was available in the UPHC. So because the diabetic is across all kind of category of population, even the upper class people started coming in, because then you were getting your HbA1c expensive tests done there, because that was made available. Your retinopathy screening was made available. Then the footfall suddenly increased, and they started taking even the NCD medicines back. It was then they realized, oh, we are getting free. We have to take it every day. Why spend when we are getting good medicines in our own neighborhood? So that will also bring in. So you need to work in with business as usual will not bring in your APL. You might have to also look at the morbidity pattern. That is where when you say mapping of the population, it's not just about the demographics. It's also about the morbidity pattern, and ensure that you're responding and your health center is responding and your medical officer is responding, because how he handles poor patient may not be the same way he would be happy if when a middle class patient comes in. So even the medical officer will have to make some soft skills improvements to ensure that he retains and he is able to show. So, and other thing that you asked about the digitization, especially actually Mysuru is the first UPHC to be digitized as per the ABDM in Karnataka. So in that sense, first digitization has to happen at all levels before you bring in CDSS, because CDSS is a very more area, high-end kind of a digital application. But basic HMIS and even the basic recording of, for the continuum of care for the patient to ensure that the repeat visits are, digitized, so that his prescriptions are digitized and what is his history and everything needs to be kind of as a first level to be done. So digitization, you can start with getting ABDM softwares into the system before you start in the CDSS, because sustainability will be a problem because across systems it has to be standardized for digital applications.
So we can just now have the closing remarks and we can continue this conversation outside over tea. So Sanjay, over to you.
Thanks, Priyadarshini. We're on time, so I'm going to just take about 15 minutes. You would ask me to speak on sort of where to from here. It's very hard to say where to from here for a discussion like this. But I think the first point is just where is a piece of work like this located? And I think it's very important because more often than not, discussions are on technical aspects. How do you design a health system? How do you design an education system? And while that's very important, the question of what is the uptake of this and why is the uptake poor, if it is poor, is not often discussed. And that's where the whole issue of politics and drivers and all that comes in. So it's really fundamental because one can have the most perfect design and not have an, let's say an optimal uptake, in which case the resources are wasted. So that's just to say the study is very important. I think one takeaway for me is really to understand how have the drivers changed and why they've changed. There was a mention, you made a mention of social movements. There was a time when social movements were doing a lot of driving of what is needed. But perhaps contexts often change, and there are times in a country's history or even local level history where maybe that's not what is needed. There are other stakeholders that play an important role. So it's important to identify what those stakeholders might be. They could be professional associations, there could be others. So I think it's important to understand that and and therefore related to that, what are the pathways? One key driver really is the community. And at one level that goes without saying, but in the context of community, I just want to sort of put our attention to what are the mechanisms for communities to actually engage with policymakers, and do we have enough mechanism to do that? There was reference made about governance and local governance, panchayats, they're very important. How strong are our panchayats? Are the community members being able to engage with elected representatives? Because, if we were to look at the whole principal agent framework kind of a thing, those are the only ones we can hold accountable. Citizens can't hold bureaucracy accountable. You can hold accountable those you've elected. So what are the processes and what are the platforms through which that engagement is happening, and how might that be strengthened is very important. I agree on the issue of packaging, these interventions and also getting the non-poor to use, but that's, I think, a bit of a wicked problem, isn't it? Because even the poor, as you mentioned, are moving away from, let's say, government schools. So if they're moving away, how to get the non-poor to come and use them? And then that will depend on quality. So if the quality is good, non-poor will use, but to improve the quality, you need the non-poor to. So it's a really wicked cycle out there. So yes, I think the main takeaway really is for the community to play a much larger role and for us to find platforms and mechanisms to do that. Thank you. It was a great discussion.
Thank you, everybody.